Hello everybody and welcome to this Mental Health for All webinar brought to you by United for Global Mental Health, Lancet Psychiatry, Mental Health Innovation Network and the Global Mental Health Action Network. This session today has been organised by the International Initiative for Mental Health Leadership. My name is Steve Appleton and I'm the European lead for that organisation. I should let you know that this session is being recorded. If you want to use social media to promote the messages from this session, please use the hashtag #MH4All when tweeting about the webinar, and please do feel free to do so throughout. This session will last for 45 minutes. If you have any questions for the panel, please submit them to webinars@unitedgmh.org or do write them in the chat box. So without any further ado, I'd like to introduce our panelists, but firstly say a little bit about the International Initiative for Mental Health Leadership, or IIMHL for short. The organisation was created in 2003 to assist in global learning about mental health and to respond to the need for more rapid knowledge transfer about mental health programme development and innovation. Among international organisations working in mental health, IIMHL is unique in that its primary focus is on leadership development through building international collaborations amongst leaders and the rapid exchange of innovations to community services, including support for the development of emerging leaders. As I said, my name is Steve Appleton and I serve as the European Regional Lead for IIMHL, coordinating activity across the whole of Europe, but working closely with colleagues in the US, Canada, Australia and New Zealand. I co-convene our International City and Urban Regional Collaborative with my colleague Cathy Langlois, who joins us as a member of the panel today. My work in public and population mental health commenced with the development of Thrive West Midlands in the UK, including writing that report and then going on to be the lead author for the development of Thrive London. And I've contributed to the development of Thrive Amsterdam and supporting work in Stockholm currently to develop a population-based public mental health programme. My colleague Cathy Langlois is the North American lead for IIMHL, and she works in coordinating the work of the organisation across the United States and Canada, as well as with my colleagues in Europe and Australasia. Cathy has significant experience of working on a range of population mental health and substance misuse initiatives and brings her knowledge of having worked in the public service sector in Canada. With me, she co-convenes the iCircle Collaborative for IIMHL, which brings together city and regional leaders who are working on public mental health programmes around the world. Cathy has contributed to the development of a population mental health playbook, which is a compendium of resources and assets relating to good practice in this field. We're also delighted to be joined by Sean Russell, who is the head of Thrive for the West Midlands Combined Authority in England. Sean served as a senior police officer for 30 years and was the force lead for mental health, and went on to lead to development in improving criminal justice responses for people with mental health problems in that area. Sean was a key shaper of the Thrive West Midlands Mental Health Improvement Plan and has led the implementation of a range of public mental health actions. He's also led efforts to establish and embed a cross-sector approach to population mental health improvement, working with a wide range of stakeholders. He's also provided developmental advice to colleagues developing similar programmes, notably in Bristol, Amsterdam and Stockholm. We're also joined by Nina Acco Weston, who is the Associate Director at the Wellesley Institute in Toronto. Nina has dedicated 20 years to fostering mental health and wellbeing through public policy, system planning and community development. Prior to joining the Wellesley Institute, Nina held management and director roles at the Centre for Addiction and Mental Health, Ontario Ministry of Health and Long-Term Care, and the Canadian Mental Health Association in Ontario. During her tenure with these organisations, Nina has led multi-sectoral initiatives, including equity and population health approaches. Nina leads work on Thrive Toronto and is working with IIMHL to develop a how-to guide for cities that are seeking to embark on public mental health improvement programmes. So our aim this afternoon is to talk a little bit about the development and importance of population and public mental health. Far too often, this discourse takes place on the margins of other areas of mental health and population development, and we're delighted to have the opportunity to share some experiences about the importance and the effect of population and public mental health and well-being. A series of questions that I'm going to put to my fellow colleagues here, and I'd like to start off by turning to you, Cathy, if I may, and thinking about how we achieve focus on public mental health, we know that that can be challenging at times. I wondered if you could give us some insights in your view about what the benefits of a public mental health and population mental health approach are.
Thanks, Steve. Yes, I'd be happy to talk about the benefits of a population and public mental health approach, which I feel are many. The approach seeks to work at the level of the determinants of health. So things like racism, poverty, food security, education, housing, community cohesion, inequities, which we all know have major impacts on the mental health and well-being of community members. In doing this, the approach is to prevent mental ill health and to ensure mental well-being and resilience. The approach works at a whole population level and can avoid the ever-increasing need for treatment, for which we know resources are often outmatched. So essentially, a population and public mental health approach works upstream, and I don't know if you've heard of this analogy, but upstream to prevent the bodies from being put in the river, where someone downstream pulls them out in order to treat or save them. Working upstream is the ethically and morally right thing to do when suffering can be prevented in the first place, and that's what this approach seeks to do. Cities are currently home to more than half of the world's population, and they play a very important role in creating the environment and the infrastructure that is needed for people who live in them to be well and to thrive. And that's why action at a population and public mental health level makes sense for cities to adopt. The cities themselves often have the levers that contribute to either positive or negative determinants of health, of mental health, and they also suffer the consequences of poor well-being when you see crime rates and violence taking place in cities. So as a result, cities are especially motivated to take on the population and public mental health approach so that they can contribute to the overall well-being of their residents. And the benefits, therefore, of the public mental health approach are attention really to the basic needs of the population, because doing that drives community safety, individual and economic productivity, collective action to actually problem solve, and ultimately the mental well-being and resilience of all people within that city or community. So that's how I'd respond to your question, Steve.
Thank you, Kathy, for such a fulsome answer. And I think there's a lot that I think both Sean and Nina will draw on in terms of the practical application of some of that. But I think particularly the issue of prevention upstream is one that will loom large in our conversation. So, Sean, I wondered if you could tell us a little bit about Thrive West Midlands and how that fits in within a preventative mental health approach, and also thinking about some of the particular communities that you might have sought to reach, given the diversity of the West Midlands area.
Yeah, thank you, Steve. That's a really, really good question. And I think it builds on the work that Kathy has just described, really. So we understood in the West Midlands that actually to try and get to the bottom of improving the mental health of the region, we really needed to understand what the cost was to our region. And actually working in a position as an official within the local authority, we were really clear about where we could provide our best course of action. Because actually, if you think about the whole of the mental health agenda, it's very big. And actually, if we were to try and tackle everything, it'd be a bit like boiling the ocean. Really, really difficult. So we started to focus on some key areas of business. So for us, it was really clear that we would focus on the working age adults because we had some legitimacy in that space, because we had responsibility for housing, we had responsibility for transport, we had responsibility for education and skills and workforce development and the economy. And that was through our directly elected mayor. So it gave us a standpoint to be able to work that through. So to start off, what we started to think about, where were the key elements that we could really focus on? And workplace wellbeing, for me, is probably one of the biggest issues. In the UK now, most people are now having to go into work until they're 67 years of age. So actually, that's probably 50 years of working life. It's a really worrying thought for most of us, actually, but actually that's the way of the world that we're in now. And actually, how do we ensure that actually we have people in a captive audience during that time to be able to do something that really helps to keep them well? So we recognise the impact of poor mental health in the workplace. In our region, which has a population of about 2.9 million people, we were losing 4.1 million working days a year just through poor mental health. It was costing us £16 billion. Really, really difficult. But actually, the sharp end of it was we were losing about 530 people a year through suicide. And that actually was really, really significant too. So we started to think about how do we put all of that together to come up with a plan. And Steve was a great advocate, actually, working with some key specialists in the region to develop our plan. So what we wanted to do is actually how do we work together to keep people well in the workplace? How do we ensure that people who aren't able to work through disability or through different mental health conditions and poor physical health, we try and encourage them into the workplace, and we make those areas very culturally sensitive to those agendas. So we're trying to break down the stigma attached to mental health, which is at the heart of what we try to do. And therefore, we run a number of programs: Thrive at Work, Thrive at Work, Thrive into Work. We did a Thrive at Home as a COVID response to think about people now working in that space, and broadly trying to have an ambition where we would train about 1/6 of the population in mental health awareness in our region. So really focusing on that. But I think the point that Steve makes about the particular cohorts and particular communities, as a senior police officer, I was really clear that some of our communities were absolutely inversely affected by the impact of poor mental health. And certainly I saw lots of evidence from our young black community where they were more likely to be stopped and searched by the police. They'd be more likely to be detained under the Mental Health Act. They were more likely to spend longer time in the hospital setting trying to get well, and they'd probably spend more time in prison. So actually I was really determined to work through that process to say, actually, how can I break that cycle? How can I build trust within our communities to enable us to, as positions of authority, recognise that actually we can work together collectively and try and break down the stigma that says, actually, let's come forward and have an asset-based approach. So we give people the tools to look after themselves very early on to help them get into that position around wellness, so we don't move to stress and then distress. But actually then how do we stop people moving into the further position where they actually need acute medical care? So therefore, when they're at that stage, it's a lot more costly, has a bigger human impact, and therefore has a much bigger challenge for our services. So if it's okay, I'll leave it there and we can pick up any questions as we go through, Steve.
Thank you, Sean. That's terrific. Thinking about some of the reasons why we might embark upon a population-based approach, Sean sort of articulated some of the experience in the West Midlands. But Nina, turning to you, what has been the catalyst for embarking on a public mental health approach in Toronto?
Thank you, Steve, and thank you all for this opportunity to tell you about what we're doing in Toronto. Toronto is a city with a complex mental well-being story. While diversity is our strength, equity is our challenge. Many players, but the question is who leads and what is the plan? And that's where our Thrive Toronto initiative came into play. So the high social and economic costs of mental illness across Toronto, similar to what Sean was just speaking about, and the high disparity in prevalence and mental health outcomes among different populations, as well as the frustration of the continued suffering resulting from mental illness and addictions, despite immense effort on the part of our local organizations, all catalyzed a public mental health approach in Toronto. Toronto is the largest city in Canada and one of the largest in North America, with over 3 million people. It is a vibrant, diverse, and growing city, but poor mental health exacts a devastating social and economic toll. 1.5 million people experience a mental health issue over any 1 year, with an expected $17 billion cost in lost productivity over 10 years. People in greatest need are unable to access coordinated, holistic, and comprehensive support. And while Toronto has hundreds of organizations doing extraordinary work, we still see barriers to good mental health and people struggling to gain access to the things that they need to be well. As I said, Toronto is a highly diverse city with 52% of our residents identifying as racialized people, just under half being born outside of Canada. Income inequality has worsened significantly over the past 2 decades, exacerbated by a rise in precarious work and rapidly increasing costs in housing. Initial data show that racialized and lower income groups are disproportionately affected by COVID-19. People with low incomes are 2 times more likely to have trouble coping and have had suicidal thoughts. 43% say their mental health has declined due to COVID-19, and racialized populations are also more likely to have trouble coping. So the high social and economic cost, the high disparity in prevalence and mental health outcomes, and the frustration of the continued suffering despite our immense effort across the city is what catalyzed Thrive Toronto members into action. They recognize the need for contributions from across society, like Kathy spoke about, and the need for that improve the conditions in which people live, a focused, coordinated, multi-sectoral approach, including government, civil society, public, volunteer, and private sectors, and a space where local leaders ranging from different sectors can share knowledge, strategize, and innovate to collectively prioritize and improve mental well-being across the city. Unlike other tables that focus on mental illness, Thrive Toronto is fostering the mental health and well-being of all our Torontonians by optimizing existing public and private sector resources and collective action. And that's what got us into action, Steve. Thank you.
Thank you, Nina, for such a helpful and fulsome analysis, really, of some of the factors behind why Thrive Toronto has developed. And there are many similarities, I think, with other cities and indeed some rural areas that are moving in this direction. And I think you describe really coherently the kind of what's often described as the moral and economic imperative to take a population-based approach. Turning back to you then, Kathy, I wondered if you could describe for us all how IIMHL as an organisation brings together leaders, particularly those in cities, to support public mental health approaches.
Sure, Steve. So in terms of how the idea of bringing city and regional leaders together came about, it arose at the in 2015 at the IIMHL International Leadership Exchange in Vancouver, where Dr. Arthur Evans, who then was the Commissioner for Behavioral Health at the City of Philadelphia, made a presentation on change management and bringing a trauma-informed approach to his city. And you could see right away the city leaders from Vancouver were literally bouncing off the walls with everything he was saying was making so much sense to them. And so we could see, oh, there's a need here for city leaders to talk to each other about their issues and the work that they could possibly be doing to learn from each other. So we then did a study tour to go to Philadelphia, and we were joined by leaders from Thrive New York City and from West Midlands, just as West Midlands was getting going. Then we did a site visit to Sydney, Australia in 2017 to learn about how city planners take into account mental health and well-being in their work, just as the city of Sydney was expanding greatly into new communities. You know, West Midlands was one of the leaders in taking the idea of Thrive back to the UK. And then we've seen London Thrive, Black Thrive London, Thrive Bristol. Now we've seen Thrive Amsterdam, excuse me, in 2019 due to some of your work, Steve, there, as well as the ongoing initiatives in Stockholm, Toronto, Glasgow, and Pittsburgh. And we now are seeing Auckland and Sacramento in California coming down the pipe. So as you can see, this is a bit of an international trend where cities in all the continents are starting to talk with each other and learn from each other. What we've done now is bring these leaders into a group called iCircle that you've referred to, Steve, and more leaders are joining who are learning about these initiatives and learning how to exchange knowledge about what is working in cities from a population and public health, mental health point of view. We recently had a lot of our dialogue, as you know, with COVID has moved from being face-to-face to online, virtual, and in fact, we're talking much more frequently because you can set up a virtual meeting pretty easy. And a lot of the discussions have been around COVID and how the pandemic has emphasized that addressing the determinants of health is key to supporting mental health and well-being, including bringing forward some lessons from COVID about this approach within the new normal. Some examples of things we've reflected on are how to preserve income and food security during lockdowns and how this supports mental health. And we have real life examples that we could point to. In the city of Auckland, they quickly learned how to house the homeless, which they never could solve the problem before, but they did it because of COVID to protect them from the virus and obviously to contain its spread. So some lessons learned there for sure around housing. In terms of how racial inequities have been exacerbated by the virus, we know that those living close to the poverty line and many people of color are the essential workers, and they need to be recognized and protected for the roles that they are playing. So it's really causing us to think differently in some ways about the determinants of health, but just driving home all the points that we've known all along and really making them real. So prior to the pandemic, the IIMHL group had worked on a declaration of principles and created a playbook with all of the examples from the many cities that are a part of the group that is essentially an asset bank because it identifies what the initiative is and how people can access those who are the knowledge keepers of those initiatives to learn more about them. So we call it an asset bank. Currently, we're working on a how to get started guide, and I want to acknowledge Nina and even Sean, who's going to be doing a little bit of work on that, but Nina's been leading it. And it's for those cities who want to know, wow, we want to do some work on this, but how do we even think about where to go to get going on it? Recently, we've also collaborated on a statement of opportunity coming out of the pandemic, an opportunity for population and public mental health, and particularly around climate change. And we've been able to link in with colleagues from the Global South who've been very interested in that initiative as well. And our future plans for IIMHL are to begin to expand to leaders in the Global South, but also to leaders who work with those who live with a disability and leaders with a disability who are all going to be connected into the network as we move forward. So that's some of the work about how IIMHL connects leaders around population and public mental health.
Thank you, Kathy. That's great. And so turning to you then, Sean, you've been part of that group for a while. And I wondered in just a couple of minutes if you could say something about the value of international collaboration and knowledge exchange in thinking about how you've refined Thrive West Midlands over the last two or 3 years, and indeed the benefits that you might have brought to others in the collaborative from your own experiences.
Thank you, Steve. And I think it's I'm very lucky. I work with some amazing people like Nina and Kathy and Steve across the world, really. But I think let's start at a very granular level. It can be a very lonely place as an official working in local government, trying to understand how you are having a conversation with your colleagues, because actually public health up until the pandemic was one of those conversations that actually no one really knew, didn't really understand, didn't really think it was in their gift to be able to do anything about. And actually that's seen a real shift actually since the pandemic, because actually it's put public health right at the heart of local government actually. And I think that's so important we recognise that. But actually, I've been banging a drum for many, many years about actually the wider determinants of health and actually how we can work as a system to make sure that people have better outcomes. And, you know, I have lots of conversations about people being described as complex, when actually the people themselves are not complex. It's our systems that we've built over the last 50 or 60 years, which is really making our whole approach to the way that individual gets service really, really complicated, and therefore not one size fits all. So for me, I think the benefit of working with our colleagues across the globe really is that you're not ever reinventing something from scratch. Actually, everything you are doing that someone has tried and tested across the world. And actually, you always think that actually I've got a great bit of innovation, and you put a reach out on WhatsApp or on the internet, and people say, well, actually, we tried that, but it didn't work, or it worked really, really well. And I think I've had most value from getting the sense of what hasn't worked actually, to think about actually, how do I learn from the bits of evidence that didn't work? So one example of that is that everyone said to me that whenever I started into the Thrive programme, that we wanted to test an incentive for businesses as a bit of a well-being grant to give small and medium enterprises, that's businesses less than 200 people, an opportunity to develop well-being in their workplace. And everyone said, you'll never make it happen. It's too difficult. Governments have been looking at this for 20 years. And actually, I reached out to my colleagues across the world and took some brilliant evidence from America, from some work in Australia, a little bit in Stockholm and Sweden. So it was brilliant for us to have that reach and just say, well, actually, how do I bring all of that together to then mobilise what would be a randomised control trial to test it out in a really effective way, which is very, very good. And I think the other bit for me is actually, I'm not a mental health specialist by core function. You know, my background, as Steve has said, I've been a policeman for a number of years. So actually, I feel that I'm absolutely embedded in community relationships and absolutely stakeholder management. But actually, I've learned so much, and I think I'm able to bring a slightly different lens to the conversation that we have about public mental health, because sometimes you come at it with a particular way in a particular field, and therefore I can ask the questions that everyone probably would want to ask, but they feel a little bit embarrassed to ask because they're in the field. So being a policeman has enabled me to have those different conversations, which I think has been really helpful. But I have to say, if you haven't joined the IIMHL, you need to, because they're a great bunch of people. But also the challenge and opportunity for you to learn is amazing, actually, and you will embed lots of learning for your own as an individual and through leadership, but also for your communities that you're serving every day of the week. Steve.
Thank you, Sean. That's tremendous. So finally, turning back to you then, Nina, given that you're embedded in this work currently and thinking about how cities might go about getting started, what sort of advice might you have for cities and regions who would be looking to initiate similar programs?
Well, I'll start by quoting our New Zealand partners from when we met last September in Toronto to discuss many of these issues. They described starting a city mental well-being initiative as organic, adaptive, painful, wonderful, and local. Meaningful relationships and inclusive community-oriented collective action, as Sean has just spoken about, can bring about impactful change in how cities address mental health. Focused resources are needed to mobilize our diverse players, co-create and implement plans to prioritize mental well-being, target mental health needs, and reduce disparities in mental health outcomes. With the right tools, anything is possible. You need to communicate, foster inclusive relationships and partnerships, develop and implement integrative strategies and action plans, and continuously measure, monitor, and improve to start and sustain multi-sectoral city mental well-being initiatives, as well as to mitigate the typical challenges that Sean spoke about that you are most likely to encounter. Implement comprehensive communication plans. We see our London partners and partners across the globe providing public awareness campaigns and mental health literacy capacity building opportunities. And that really helps to establish understanding, buy-in, and overcome possible resistance to a broader mental health approach. Keep the communication simple, clear, targeted, and provide information that resonates with your stakeholders and gives them what they need to actually take action. Achieving mental well-being for all requires a deep understanding of the stresses and strengths of your population. Include the general population, people with lived experience, and especially the segments of society with low mental health outcomes in the planning and implementation of your work. Inclusive participation is the driving force of a city mental well-being initiative. Using the initiative as a platform for these groups to share their stories and help develop the initiative's vision and action plan is an opportunity to develop innovative and impactful interventions that really reflect the needs and culture of your community. Constructive relationships with governments, civil society, The public, volunteer, and private sectors are essential. Nurturing relationships and fostering strategic partnerships with potential champions is very helpful in creating buy-in and garnering the resources and goodwill needed for impactful collective action. An integrative all-of-government approach, as Kathy mentioned, is needed to achieve population mental well-being and to spread the ownership of the initiative. This requires developing a shared and agreed upon, clear, coherent, integrative mental well-being strategy, as well as investing in evaluation, implementation, and management to support integration and efficient and effective use of resources. Starting a city mental well-being initiative is not a straightforward process. Actions need to evolve to reflect changes in people's experiences, as we've seen with COVID-19. It is important to learn and course correct along the way. This requires continuously communicating, a shared understanding of the purpose of the initiative, re-engaging regularly, and vetting and validating the work with your stakeholders, and establishing agreed upon evidence-based population mental health outcome measures and general success measures to judge the city's initiative progress. And we've seen that in our initiatives, city mental well-being initiatives across the globe. So that, in a really nutshell, are some of the key components to success and sustainability.
Fantastic. Thank you, Nina. And thank you, all three of you, for responding to those questions. We have a few minutes, probably about just under 10 minutes, to think about some questions that have been posed to us. And I'll just put them out there and see if you want to pick up on them. So the first is, what advice would you give to the population and local communities to get people to be aware of or invest in their own mental health? Having resources is great, but that needs to be utilised prior to crisis. So I don't know, maybe Sean, based on your experience, what advice would you have about helping communities and to become more aware of and investing in their own mental health?
So I think there's no health without mental health is a really good starting point for me. And actually, you know, we use a line in the West Midlands that's health and wealth are two sides of the same coin. So actually, if you're going to think about looking after your economic future as well as your health future, you need to combine the two. And I think it's really, really important that we do that. I think that we need to think about actually the marketing campaigns that we currently do and how we link all of those for a coherent approach, as Nina described, something that's really simple, something that's evident. But it all starts with us, because actually we know that as an individual, you can't operate to support anyone else around you if you're not operating yourself. And I think it's so important that we do take that time. So we follow along the 5 steps to wellbeing and really push to ensure that people do that. So during COVID, we've seen lots of use of our green spaces, our parks, our blue spaces, our rivers and our lakes, because actually people are really starting to feel the benefit of it. I mean, I grew up in the inner city areas of Birmingham in the UK. And actually, when I wake up in the morning and go for a walk, the birds seem to cough every morning. I now live out in the countryside and they sing beautifully, but I never noticed that before because I wasn't taking notice. I was so wrapped up in my ability to get to the next meeting or get to the next job. So actually, this is about taking a little bit of time to reflect and giving people the permission to say it's okay to look after you, because if you do look after you, the chances are you will look after everyone else around you in a stronger way. So I think the message for me is very, very clear that it has to be simple. Actually maintain your own well-being. Think about how you do that very simply, making sure that actually we as a system try to keep people at that lower tier of wellness as much as we possibly can, because therefore we spend less money and actually it's a more impactful community spirit. And again, through COVID, we've seen some of the joining up of communities to clap for carers, to thank the NHS for putting lights out on your doorstep on a Thursday evening. All of those things which bring that sense of community are all part of our drive to improve the mental well-being of our society. But as I go back to, there's no health without mental health, and we need to make sure that there is a parity of esteem between physical health and mental health, and ensure that we have the conversations both with our family, our friends, but also our work colleagues too.
Thank you, Sean. Moving on to another question that's come in that asks whether there are any standout city-based collaborative initiatives that have impacted the significant mortality gap that's experienced by individuals living with severe persistent mental illness. And I think that's a really important point. We know that people with severe mental illness tend to die younger than those without it. I don't know if any of the panel members have any thoughts about particular initiatives that they're aware of that might have had an impact on this or have been designed to address it.
Well, I'll just start by saying this is where the social determinants of health are extremely important. I will also say that it is a challenge to document this and speak about this in very short periods of time. For sure, we need to continue to measure and monitor these different things. But I'll say in New Zealand, in New York, I'm sure in West Midlands and areas like Glasgow, we've seen initiatives that focus on housing, income, and broader mental health literacy having a significant impact on how people live their lives, are able to stay well and cope, and also the incidence or the use of more acute and lower level or more extreme mental illness services. And for sure, we know that having better environments to live, better working environments impacts people's broader mental health and well-being, but also impacts the incidence of deaths by suicide, deaths by alcohol, by violence, and other challenges in our homes due to domestic violence. So we're seeing that all these different initiatives are having, upstream initiatives are having impacts downstream. And for sure, our different initiatives are showing that this is where there's an opportunity to have impact.
Thank you, Nina. I think that's really helpful. And I think the other thing to say is that we know that these sorts of initiatives, those that we've talked about, are in large cities. There are other initiatives in rural communities too, and we know that part of the adaptation of this sort of program is important because one size doesn't fit all. And there's a huge amount for us in the Northern Hemisphere to learn from colleagues in the Global South, and one looks to the example of Dixon Chibanda and the Friendship Bench, which was taken to New York and used very successfully, and has also been used within London. So that sort of cross-fertilization of ideas and experiences, I think, is incredibly helpful. I'm conscious of time. I think there were a couple of other questions, but I'll be happy to pick up responses to those through United offline and provide a short written response to those if I may. In the remaining couple of minutes that we have, I wonder if between the three of you, you might just let us know what your top priority action or message might be in relation to public and population mental health and improvement.
I don't mind going first. I'll be very quick. What I just want to say is the top priority would be to engage the community and look to its assets. And I'll stop there.
Thank you, Kathy. Nina.
So I'll say improving mental health is a collaborative effort. Partnerships are the firm foundations from which we can build sustainable collective action, and building relationships and fostering strategic partnerships requires continuous and targeted communication.
Thank you, Nina. And Sean, finally, what would your priority message be?
So I think it's about how you develop both political and community leadership to drive the agenda forward, and actually, forgive me, but turn words into action. Don't let it just be a paper that sits on the shelf and gets dusty. actually make it happen and drive that through our communities and let the communities hold us accountable.
Thank you, Sean, and thank you to all three of you for joining us for this discussion today, and thank you to United for Global Mental Health for giving us the opportunity to talk about this important subject today. It's been a really helpful, I think, and important discussion. If you would like to find out more about the work of iCircle or IIMHL in particular, please do take a look at the website IIMHL.com, where you can join for free and be able to access some of the resources that we've talked about today, in particular the iCircle playbook. The recording and notes of this session will be posted on unitedgmh.org very shortly indeed. The next session of Mental Health for All webinars will take place at the same time on December the 1st, and its focus will be on mental health research funding. You can visit the unitedgmh.org website to join that conversation and to submit questions in advance of the session. So thank you again to Kathy, to Nina, and to Sean, and to United for Global Mental Health for this opportunity today. Thank you very much indeed.